Massachusetts has long been among the top states for the percentage of people with health insurance, but there's a difference between levels of coverage, levels of access, and consumer satisfaction. To sort those out, surveys are done every year by the Mass Medical Society, and to discuss this year's results is our guest from the Society, the president, Dr. Ronald Dunlap. Thank you very much for being with us, Doctor.
Thank you.
I want to talk about one of the things that you do keep tracking on a regular basis, and that's access to primary care doctors. Now, some of our viewers might be wondering, that sounds routine. Why is that such a big deal?
The primary care provider supply across the country is low. And I think that primary care providers are more or less the quarterbacks on the team. And as we try to integrate care and control costs by keeping people out of the most expensive centers, such as the emergency room, the need to have that quarterback on your team to control the ordering of tests and essentially just to sort of be your mentor in terms of directing you to the proper services is really critical.
And there's a sign of trouble, maybe not a big one at this point, but I guess one of the figures for these recent surveys is that there are more people going straight to the emergency room this time.
Well, this is an unusual year. We had more people getting care at the usual source or usual place of care, meaning that more people had primary care doctors, but there's also an increased number of patients, seeking care. And so therefore you still have a number of people, specifically in certain areas where the supply is low, where they don't have a primary care provider, and therefore when they get ill or have a problem, the only place that they can quickly get care is the emergency room.
And if I recall, by and large, these are not people who are older with advanced illnesses and complicated.
And younger patients. So that there's an issue there too, in that part of universal health care was to really ensure the working uninsured, and that was a lot of 20-year-olds who work, but where healthcare costs were so high, and they felt I'm not going to be ill, I'm well, so why do I need a doctor? However, if you have a catastrophic illness, then it can bankrupt you. So that we will have more people, younger people seeking care, and if they don't have a primary care doctor, they will end up in the emergency room. Or the other thing that's developing is urgent care centers. Some larger practices are opening urgent care centers, which are places where you can be seen quickly, up to 8 or 9 or 10 o'clock at night, where you won't have to go to the emergency room, thereby saving the plan, the patient, and everyone money.
What about access to primary care? Because is it the cost? Is it how long you have to wait? If you don't have a primary care doctor, I guess maybe it's difficult to find one who's taking patients.
I think that many of the primary care providers are more senior, so especially the independent practitioners or private practitioners are older. And so many of them have mature practices that are full. So therefore, more than 51% were not accepting new patients. So that's an issue. So that we really need to increase the pipeline of providers, providing primary care. The problem is that medical school is extremely expensive. Primary care doctors aren't compensated as well as specialists. And so therefore there's a conflict between paying off your loans, rationalizing the education you have, and being a primary care doctor. But right now, with the reorganization of healthcare, primary care doctors are key. And so I think some systems will subsidize the primary care doctors in order to get them, but still, to get them to practice in a given region, but still we're going to be very short of what we really need.
Compared to the rest of Massachusetts, the wait or at least the access to primary care in Suffolk County, which includes Boston, doesn't seem to be too bad. Is it really that good, or is there a reason why it's as good as that?
The numbers are inflated because we have teaching institutions in Boston, 3 medical schools. On the other hand, those medical schools run clinics, free clinics in some cases. Boston Medical Center is a safety net hospital, which does more care of poor and indigent patients, so that there truly is an increase inside 128 and certainly in Suffolk County. However, when you really drill down to the people providing care on a full-time basis, those numbers are smaller. We have a lot of people who teach. I did this myself part-time, who do a clinic a half day or so a week, but are teaching medical students the rest of the time, so that they're all counted in the provider supply, so that swells the numbers. But when you actually look at, I think statewide we have about 4,500 primary care doctors out of 28,000 registered doctors.
Well, here in Boston, we have neighborhood health centers that have been expanding with a lot of help from the federal government. East Boston, Dorchester, Mattapan. The infrastructure is there for more access, but what about what the patients are actually experiencing?
I think there's pretty good access in those centers. One of the unintended consequences of universal health care is there are now copays. So in many instances, patients had completely free care before, and now they have to pay $10 or $20 when they come to the doctor. So sometimes in some of the clinics, there are actually there's a higher no-show rate of people who are not making their appointments because of cost. So whenever you raise the cost to the patient, and we're doing that, as you heard on the radio today, with healthcare insurance going up, yet the amount that each patient has to pay or the copays are higher, and that essentially discourages care. So there's a problem there when you place more on the consumer. Some people are reluctant to come for care.
If you look at consumers in general, there's a mix of feelings here. They like the care, but they do worry about the cost.
I think that's true. I think that everybody's very sensitive to the cost, that we have some of the finest institutions in the country, but teaching institutions by their very nature use more money. The people with the least experience probably order more tests, so that when you're in your training and you're not as experienced, you don't hone in on your diagnosis as well, so that you may order 2 or 3 more tests, whereas an experienced provider with more may say, I don't think I need these other 2 tests. So that's just that we all will evolve that way. And so that's an issue in terms of even bringing nurse practitioners. It's not bringing nurse practitioners in that's a problem, it's bringing experienced nurse practitioners in. So if we increase the provider supply and put 1,000 brand new nurse practitioners out there, that may not impact the provider supply in the way we want in terms of saving costs and being more efficient. We need people to have the time to train and get experience.
Historically, this is a state with a fairly high percentage of people getting fairly solid employer-sponsored insurance coverage, but what about people who rely on the government for insurance, whether it's Mass Health or Medicare? Are they getting comparable levels of satisfaction, you think?
Well, I think that's part of the problem. I think the wait times are longer in the communities where there's a high density of Mass Health patients, for instance, because the provider supply in those communities for physicians accepting Mass Health is lower, because the viability of a practice depends on having a payer mix, which means private insurance, some Medicare, some Medicaid, some Mass Health and Medicaid. But if you have 90% Mass Health, which reimburses very poorly, you may not be able to keep your clinic open. So many of the community health centers are subsidized, and that's whereas a private practice might have difficulty providing care without a government grant or some other source to support it, where you have a high concentration of patients within a certain insurance type, particularly public health plans.